And I think I can't overemphasize how important survivorship groups, people that have had lung cancer in their families, raising money and also raising public awareness how important it is for getting support for research to help with lung cancer, both with screening, treatment, survivorship, and everything. When you look at how funding goes for different cancers, it is not directly proportional to how many people have cancer, how many people die of cancer. It has more to do with how much public awareness there is, how much the survivorship groups and support groups for different cancer groups, like breast cancer, push the public awareness. Okay, so it's wonderful to see you all out here today, because in addition to all the folks doing research, you all have a major role to play in how we can improve things in lung cancer going forward. Okay. There we go. Great, thank you. Okay, so when Lung Cancer Initiative started about 20 years ago, all non-small cell lung cancer was the same. Adenocarcinoma, squamous cell carcinoma, it was all treated with the same medical therapy, the same surgery, the same radiation. There were no effective biomarkers. We were still helping people, but we were not able to choose the right treatment for the right patient. There we go. So now we've moved forward. This is a pie chart for an adenocarcinoma of the lung. And these are different oncogenic drivers, what we refer to as actionable alterations. This is very different than the last slide we looked at, where it was just one monotonous pie, all the same. So now we have a host of different potentially actionable alterations. EGFR mutations, ALK translocations, MET amplifications and mutations, HER2 mutations. So HER2 is really well known for breast cancer, but in lung cancer, about 2 to 3% of patients have mutations in the HER2 gene that causes the cancer. And there's now a new FDA-approved molecular antibody drug conjugate for that specific subtype of lung cancer. ROS1, BRAF, RET, all these different cancers that we can now treat with molecular therapy. The toughest nut to crack has been KRAS. So KRAS is one of the most common oncogenes in all of cancer. It's the most common oncogene by far in cancers of the gastrointestinal tract, like pancreatic cancer, for instance. But it's also the most common oncogenic driver in adenocarcinoma of the lung. And now we have 2 different approved molecular therapies for the most common KRAS variant, KRAS G12C. And KRAS G12C, in total, has about the same number of cases each year in the United States as all the epidermal growth factor receptor lung cancers. So we now have 2 oral therapies approved in that particular molecular variant. So these are some of the biomarkers that we have, where we can test the tumor. If we find that actionable alteration, we have a molecular or an immune therapy to preferentially treat that cancer. Now we look at percentages of cancer, and gee, it's 10%, it's 2%, it's 5%, and you think it's not much. But unfortunately, there's a lot of lung cancer. So if you look over here on the far right, CML is chronic myelogenous leukemia. And that's a very famous chronic leukemia because it was one of the first cancers that we found a specific molecular target called the Philadelphia chromosome, or BCR-ABL. So back in the mid-1990s, Gleevec, a molecule that blocks that particular abnormality, was identified and had transformed the treatment of the disease. Famous cancer. There are 5,000 total cases, new cases in the United States every year. If we look at a relatively uncommon lung cancer, the ALK lung cancer, there are twice as many cases of ALK lung cancer as there are for all of CML. When we look at EGFR lung cancer, it's more than 3 times as much. Look at KRAS, it's 7 times as much. So when you look at these molecular subtypes of lung cancer that we now have treatments for, that's a lot of cases, that's a lot of people that can be helped. Now this is going to be a little bit complicated. You've probably all heard about immune therapy in lung cancer. You probably haven't been able to escape television ads for immune therapy in lung cancer if you watch television at all. Okay? And this is complicated. You're not alone. Medical oncologists had to kind of get on board with this and kind of teach themselves a little bit of immunology starting about 10 years ago. Okay, so about 10 years ago, I was about where you are right now, probably, in understanding immunology. Okay, so right here, these little gray things here, that represents the cancer. Okay, so that represents the cancer cells. Cancer cells tend to have a lot of mutations. Mutations are abnormalities in the genetic material, abnormalities in the DNA of the tumor. That doesn't mean that you were born with it, it doesn't mean that you could give it to your children, okay? It's just cancers have a lot of mutations. Those mutations lead to abnormal proteins. So the DNA gets coded into mRNA and makes a protein. So cancers tend to have and make proteins that you were not born with. So therefore, the immune system can recognize those proteins as foreign, just like they look at a bacteria or a COVID virus and say, aha, you're abnormal, I'm going to attack. These mutations in the DNA that lead to abnormal proteins make the cancer cell look like a foreign invader to the immune system. And the key component of that immune system for cancer is the T cell, or lymphocyte, the T cell, okay? And this is sort of and this is sort of a cycle of how the immune system recognizes the cancer. Okay, so you've got these cancer cells that make abnormal proteins. The garbage men, or garbage people, of the body, the macrocytes and the monophages, what we call antigen-presenting cells, scoop up that protein. They digest it, cut it into pieces, and then out in a lymphocyte, out in a lymph node, which is an immune organ, those antigen-presenting cells show the protein bit to the lymphocyte. And if it's a match, like a lock and a key, if it's a match, then the lymphocyte gets all activated, circulates back to the tumor, and can attack it. Now, there are multiple ways along this pathway that the immune system can be blocked, ways that the cancer can evade the immune system. So, one of the things that can happen is right around here in the lymph node, there can be too much inflammation and it blocks the antigen, the peptide, from being presented for the T cell, so the T cell doesn't get activated. The most important point where inhibition can happen is at the tumor. So, again, you've got a protein, it gets released, it gets gobbled up by an antigen-presenting cell. Out of the lymph node, that lymph node, the protein bit is shown to the lymphocyte. If it's a match, the lymphocyte activates, circulates back to the tumor, and attacks, okay? The most important inhibitory checkpoint is called PD-1. That's an off switch where the cancer can turn the lymphocyte off, okay? So right there, that happens at the tumor, okay? So this is an up-close look at that checkpoint. And this is where all the immune therapies like Keytruda, Opdivo, Concentric, Imfinzi, Cemiplimab, this is where they all worked, okay? What happens is this. Here's our T cell. So this is the lymphocyte, right? When I'm explaining it to patients in room, because I have to sometimes sit in a room with somebody with lung cancer and try to explain how this all works, right? Sometimes I will use an analogy that the T cell is kind of like the Pac-Man of the body. You know the old computer game with the big things going across the screen with big mouths gobbling stuff up? That's what the T cells are like. They're like the Pac-Man of the body. Going around gobbling up whatever doesn't belong, and sometimes what doesn't belong is a cancer cell, okay? So here we have a tumor cell with that abnormal protein. The T cell recognizes it, and it can attack. It can attack that tumor cell and kill it, all right? But if there's a lot of inflammation going on, the T cell, the immune cell, expresses the PD-1. The tumor cell expresses a protein that can flip the switch and turn that T cell off and just paralyze it, okay? That's the most important way that cancer cells evade the immune system. The antibodies that we use, Opdivo, Keytruda, Concentric, Imfinzi, Cemiplimab, Avelumab, other ones, what they do is they block that. Right here in yellow, the protein either binds to the PD-L1, okay, and that would be Concentric and Imfinzi, or the antibody binds to the PD-1, that would be Opdivo, Keytruda, Lutathera, okay? They short circuit the inhibition, and now the T cell can attack the tumor cell. I know that's a lot to kind of wrap your head around. Any questions right now? Yes?
So, just two questions actually about this. So, can patients be cured with immunotherapy? Or like, how long have you seen a patient?
Coming down.
Okay.
Okay, so. All right, so. In August 2012, a woman out in New Bern was diagnosed with a squamous cell lung cancer. She was in her early 40s. You know, she had smoked when she was younger. She had a squamous cell lung cancer, which is typical cancer for somebody who has a smoking history. She had surgery to remove that tumor that was about 4 or 5 inches in size from her right lung. She then received chemotherapy after the surgery. Right at the end of the surgery, right at the end of getting the chemotherapy in January of 2013, she developed right chest wall pain. Okay? And by February or March, she had a tumor. Okay, so this is a CAT scan of the right half of the body. Okay, so this is the right lung. This is the right arm. All this is cancer. These white things are ribs. So this is a tumor that's about 6 or 7 inches in size, eating away the chest wall. And she had just progressed on chemotherapy. Okay? So we didn't have any, this was a type of cancer we don't have any molecular therapy for. She was in pain, she was on long-acting opiates. And she was referred in, and we had a clinical trial where she was going to be randomized between a second-line chemotherapy and an immune therapy, nivolumab, also known as Opdivo. So she went on study in April 2013. By July, the tumor had gone from this to that. By October, she'd had a complete response. There was no evidence of cancer. She was having no discomfort. She received years of immune therapy and then came off. And she remains in a complete remission well over 9 years later. So are we curing some patients with advanced lung cancer with immune therapy? So I think everybody that's done a lot of this research thinks we are. I don't know what percentage. But there's a substantial number of 5-year survivors with immune therapy, so much so that that has influenced the overall cancer data in the United States, as kept by the American Cancer Society. So over the last 10 years, overall survival has improved for all cancers. Where you say, well, all cancers, what's the average survival in the United States? Okay. And improvements in survival for advanced non-small cell lung cancer has been a major component of that overall increase, which I had not suspected, but the data is very clear. So that's an incredible step forward. So now, immune therapy was rapidly instituted and tested in first-line treatment. Okay? So our paradigm right now is that for someone who presents with an advanced lung cancer, non-small cell lung cancer, one that we cannot do curative surgery on, or one that we cannot do curative radiation-based treatment on, if the patient has a non-squamous lung cancer, typically an adenocarcinoma, we do molecular testing to look for that actionable alteration. So that would be a test either on the tumor or on tumor DNA in the blood, so either biomarker testing on the tumor or biomarker testing on the blood. If we identify an actionable alteration like an epidermal growth factor receptor, then that person will get an oral molecular therapy. If not, then they will get immune-based treatment, with the hope that that patient could live a very long time. That's different than when LCI started. So we're now in a position that for 95% of people with advanced lung cancer, when we meet them, if they look at us and say, is it possible that I'll live 5 years and do well? I can absolutely look them in the eye and say yes. And I couldn't say that 20 years ago. So it's a huge step forward. We can't cure everyone. We can't have everyone live 5 years. But what we can do is we can give almost every patient hope that they will live a long time and do well. And that's just in the last 20 years. Yes?
Have you seen work for issue with lung mutation? Because a lot of times what I've been hearing is that EGFR, you can get doesn't work for EGFR.
So that's a good question. So the question is, there are certain actionable alterations that typically are associated with, they are associated with non-smoking. So EGFR, ALK, ROS, RET are much more common in non-smokers than in smokers. And the data is pretty clear that if somebody has one of those abnormalities, they're less likely to respond to immune therapy. Okay? But I've seen it happen, so it can happen. So and there's a lot of research that's going on looking at that. There's some data from a trial called Empower 150, where patients received a quadruplet of chemotherapy, 2 chemotherapies, bevacizumab, or Avastin, which is an anti-angiogenesis agent that blocks blood vessels, plus the immune therapy Tecentriq, also known as atezolizumab, where there were promising results in the EGFR mutated patients. So, that's an area of active research, but to answer your question, it's less likely. It's less likely. Yes?
I think that one is that another biomarker that we should use to see the
So, right, so as you're pointing out, PD-L1, programmed receptor ligand 1, is a protein that we test for on the tumor cells. And if it's high, then you're more likely to respond. If it's lower, you're less likely to respond to immune therapy. But it's not all or nothing. It's not binary. It's not yes, no. It's just more likely versus less likely. Okay? There's another tumor marker that I put some stock in called total mutational burden. And that is something that is associated, if your tumor has a lot of mutations in it, particularly more than 10 per megabase, probably there's an increased likelihood. In general, the EGFR mutated lung cancers typically are low PD-L1 and low total mutational burden. And that's probably because most EGFR lung cancer is in non-smokers, and the non-smoker cancers tend to have less mutations. Yes?
Wondering the MET switch, if you have a high MET switch and a high PD-L1, I don't understand how that works in turn.
So it is possible to have an actionable alteration and have a tumor that's high PD-L1. If it's a validated actionable alteration, that trumps everything. Okay? So if you have an EGFR mutation and high PD-L1, you treat the EGFR mutation.
How does the MET switch fit in that if you have a high MET switch?
MET?
Yeah.
MET?
Yes.
So sometimes tumors can be amplified from MET. Sometimes they can have a deletion mutation in exon 14 that eliminates a protein that takes MET off the cell surface, so you have an over-accumulation of MET on the tumor cell surface that can drive the cancer. So that's how the MET works. It can sometimes be amplified. It can sometimes be amplified on the cell surface due to a particular mutation removing a piece of the MET protein. And there are some, for tumors that are MET highly amplified, or the MET mutation is present, there are a couple of effective oral MET therapies.
Can you combine that with an actionable mutation therapy though?
So MET is an actionable alteration.
Like an ALK. Can you do like an ALK and MET together?
So generally they're not together at the time of diagnosis, but sometimes the MET can be an escape mechanism. So like if you had an ALK lung cancer and you were on an ALK drug like alectinib, for instance, for 2 or 3 years, and then you retest, okay, sometimes you develop a MET amplification as an escape mechanism around the ALK inhibition. And there is some data that then treating the MET, the new MET driver can be effective. Okay. So, actionable alteration trumps everything, okay? But if you don't have an actionable alteration where you're going to take an oral therapy, then we look at immune-based treatment, okay? If the tumor has a lot of the PD-L1 antibody that we were talking about, then we can treat with immune therapy alone, okay? And the 3 drugs that are approved are listed here: Keytruda, Concentric, and Luteo. Those are the generic names. But there's no generic form yet, so it's all the same. And there are instances also where we will treat with chemotherapy plus immune therapy. That's sort of a clinical decision between the physician and the patient. If the PD-L1 score is low or negative, then we tend to treat either with chemotherapy, immune therapy, or sometimes double immune therapy with nivolumab and ipilimumab. And that's true for both non-squamous and squamous. And all of those have the potential to produce a good outcome. You know, it's clear that with all these treatment approaches that are immune-based, there's a significant chance of 3, 4, 5-year survival. So for all these scenarios, there's hope for doing well and doing well for a long time. A lot of people are trying, yes, please. Yes.
What's the difference between a mass and a tumor? Are they the same?
So if somebody had a CAT scan and there was something there that didn't belong there, some abnormality, we would call that a mass. Once we biopsy it, and a pathologist who's read the biopsy tells us that it's cancer, then we know it's a tumor.
But do they always biopsy? I mean, I was told I had a mass, but I was in biopsy.
So generally we do something to make a diagnosis. There could be scenarios where we're so highly suspicious that it's a cancer, and maybe a cancer that might be EGFR, that we could do blood testing, and if we found the EGFR mutation in somebody where it wasn't safe to do a biopsy, that we might call it cancer. But in general, yes, you have to have some sort of a biopsy to make a diagnosis. Yes, please.
When you're going back to molecular therapy,
Yes.
trumping everything else.
Yes.
Is there any way with an initial diagnosis that you can tell whether or not molecular therapy is going to fail, and is it going to fail in a rapid fashion within months because of some innateness about the tumor itself? Something that can be tested.
Generally not yet.
Tumor mutation burden doesn't have anything to do with that.
Not that I'm aware of. Yes.
If you go back one slide, so I can't see very well, but I don't
Yeah.
see on any of those where there's SBRT and radiation, chemo, and immunotherapy.
So SBRT is generally not outside of the clinical trials. So there are clinical trials looking at adding radiation to first-line therapy. But there are no approved treatments yet where we radiate the cancer and then give like immune therapy and chemo and whatnot at the same time. There are some theoretical reasons we think that might work, because when you radiate the tumor, you might release more proteins that may stimulate the immune system and give a better immune system. But at least at this point, there's no FDA-approved treatment where we would do SBRT with the immune therapy as a strategy to get a better result.
So that was my scenario. I was
Yeah.
on the Pacific trial, so it was SBRT, radiation, chemo, and my final stage was, well, I had radiation and chemo at the same time, and my final stage was immunotherapy.
Right. So we're going to talk about using radiation in stage 3 lung cancer in a minute. But this is advanced lung cancer. This is this is cancer where we cannot remove it surgically and we cannot treat with curative radiation. Any other questions? Yes.
I know it's pretty rare, but I've heard of some people going for long periods of time on targeted treatments, like
Yes.
Tarceva.
Oh, yeah.
Is there ever a point, like if you go 10 years or more, where you would actually be considered cured, or do they just assume that you always had it and they'll just keep you on it forever?
So that's a difficult question, and for those unusual circumstances, we don't have data from like clinical trials. It's kind of anecdotal. I have had patients do well on an EGFR inhibitor for 10 years and say, boy, I'm tired of taking this, and we stop taking it and we follow them with CAT scans. I have a lady with an EGFR lung cancer who went on a clinical trial with a novel EGFR inhibitor that had a lot of toxicity, and it knocked her cancer down some. And then I just followed the we followed with CAT scans to see if it was doing with the intention of when it really took off, restarting therapy. Now it's 10 years later and we haven't started our main therapy. So cancer can behave in different ways, and it can behave in different ways in different people. So I have had patients who've been on oral therapy for a long time, and then after a discussion decided to stop treatment and then keep an eye on things. And so that's a reasonable strategy.
How common, and what percentage would you say that is, like 1%?
I would say 1 to 5%.
I guess you probably don't have anybody on Tagrisso that long because it hasn't been around like more than 10 years.
Yeah, I haven't had anybody on Tagrisso that long because, right, there hasn't been Tagrisso for that long. Yeah, thank you for that question. That's a good question. So a lot of what we're doing now is trying to figure out how do we take a tumor that's immunologically cold from the get-go, okay? Like an EGFR cancer often, where you've got a tumor that's PD-1 negative, total mutational burden is low, very few tumor-infiltrating lymphocytes. So when they look at the tumor under the microscope, the lymphocytes are not in there. Okay? The T cells are not in the tumor. And these would be tumors like estrogen, progesterone receptor breast cancer, EGFR mutated cancer. How do we rev things up and make things immunologically hot? And there are different strategies that can be tried, like radiating the tumor, okay? Using an anti-angiogenesis therapy, like the bevacizumab. Adding in other immune therapies to try to take the brakes off. Okay. And then, when we have an immunologically hot tumor, where there's the PD-1 is high, there are a lot of lymphocytes, there are a lot of mutations, and we think, okay, we just need to take the brakes off at some other level. There are a bunch of other immunologic targets later in the immunologic cycle to do multiple attempts to hit the immune evasion and get the cancer to be identified and attacked by the immune therapy. And this just shows some of the strategies that are being evaluated to try to improve and expand what we can do with immune therapy, okay? So, here's our T cell. Okay, so there's our T cell. These are all inhibitory checkpoints, like brakes on a car. So it's like a car with 5 or 6 different brakes, okay? And the reason that these are so important for us is they prevent us from getting autoimmune diseases, okay? If we don't have these brakes, we would all get lupus, psoriasis, rheumatoid arthritis, colitis. So these are really important to keep us healthy. But there are ways that the cancer can put the brakes on the immune system when the immune system is trying to attack the cancer. These are all the activation receptors. They're like gas pedals, where when you stimulate them, it amps up the immune system, revs it up, turns it on. So it's kind of like the T cell is like a car with like 5 brakes and like 5 gas pedals. And the interaction of those cause the T cell to either be quiet or revved up and attack. So there's a lot of clinical research looking at hitting the different inhibitory receptors and then revving up the different stimulatory receptors. So this is good news. There are lots of different potential strategies to make things better, but it's complicated. Years ago, decades and decades ago, we tried to do vaccines against cancer, okay? Where you take cancer cells, you grind them up, and then you give them to a patient with immune stimulation to try to get the body to recognize the cancer. And in general, these vaccine therapies didn't work, okay? They just didn't work because almost always PD-1 checkpoint is activated in cancer. So if you're not blocking the PD-1 checkpoint, if you're not using a drug like Keytruda, Opdivo, Tecentriq, Imfinzi, Liteo, avelumab, if you're not using one of those antibodies, if you give a vaccine, it isn't going to help, okay? Because the cancer has its foot on the brake, all right? So now that we know how to block the PD-1 checkpoint and take the brake off the immune system, now we can go back and look at vaccines again. Okay. So cellular therapy is now kind of moving forward in lung cancer. So actually revving up immune cells, arming them against the cancer, has been well established in blood cancers. It's more complicated than lung cancer, but this is moving forward also, okay? Not ready for prime time, but it's a very promising area of research. Antibody drug conjugates are going to be important, okay? So antibody drug conjugates are where you make an antibody against a target, for instance, like HER2 or MET, right? And you make an antibody that goes against that protein on the cancer cell surface, and you link a really nasty toxin or really nasty chemo to that antibody, okay? And what it does, that antibody comes right in on the cancer cell and delivers that chemo right to that cancer cell, rather than other cells in the body. So to make a military analogy, it's a smart bomb rather than a carpet bomb, okay? So this is the equivalent of when you're watching the news and they show a crosshairs like on a munitions depot, right? And you just see it goes home right in on it, and boom, right? So this homes right in on the cancer cell and delivers the chemo to it. And this is an antibody drug conjugate has been approved for HER2 positive lung cancer, okay? Called HER2. Okay. And there are new antibody drug conjugates coming from some other targets like TROP2, TROP2. So this is another area that's coming along. Okay, so I wanted to specifically focus on moving the new molecular immune therapies into early stage disease. Okay, so for people who have a stage 3 lung cancer that cannot be removed by surgery, we have typically treated with 6 weeks of radiation with chemotherapy, with curative potential. Okay. The Pacific trial looked at doing that 6 weeks of radiation with chemo, with or without the immune therapy durvalumab, also known as Imfinzi, after the radiation. So randomized to either get it or not get it. There was a dramatic improvement in progression-free survival for people who received the Imfinzi immune therapy. Yep. There we go. Yep. And that has translated into improved overall survival and progression-free survival at 5 years. So we interpret that this is improving cure rate in this setting. So this has been a major step forward, okay, in curing non-surgical stage 3 lung cancer. And now the clinical trials are looking at adding the immune therapy into the radiation piece, and we're looking at adding multiple immune therapies onto drugs like the durvalumab. One of the ways that we improve survival in early stage lung cancer that's been surgically removed is to give adjuvant treatment. And we've known for quite a while that giving adjuvant post-surgical chemotherapy can improve the cure rate. This is a trial that studied atezolizumab, concentric immune therapy after surgery. So patients received surgery, they received chemotherapy, and then they were randomized to get immune therapy or not. And it showed us clinically significant improvement in progression-free survival with the addition of immune therapy. It's early yet. For these adjuvant trials, it takes a long time to see differences in overall survival because patients do well. Many people are cured by the surgery. Many people are cured by the surgery and the chemo. So to get the additive benefit and see the overall survival advantage, it takes a while. But we feel pretty confident that particularly in the PD-L1 positive tumors, that giving the atezolizumab after the surgery is an improvement, and this has changed treatment in early stage lung cancer. So we're now adding immune therapy after surgery for early stage lung cancer, and this is improving cure rates. Yes?
How much time has to lie before you call something a cure?
Well, there's nothing up
I've
there.
heard people 20 years later getting it back. So I'm trying to find out, what would you consider a cure?
So it would be very unusual. So there are different cancers, okay? And it varies for the cancer. So for instance, for estrogen and progesterone receptor positive breast cancer, sometimes the cancer will come back 10, 15, 20 years later. In non-small cell lung cancer or small cell lung cancer, that's really uncommon. Usually if somebody has a lung cancer 10 years later, it's usually a new one. It's not typically the old one coming back. So it's very uncommon. It could happen, it's very uncommon. So when do we call it a cure? I think that if we're seeing an improvement in disease-free survival at 5 years, then we would conclude that the treatment is increasing the cure rate. Unfortunately, we don't have any test. We don't have a PET scan, any scan yet that can tell us if an individual is cured.
So I guess my response is you just have to, if somebody makes a decision not to take medicine and it wakes up and comes back, then obviously the cure wasn't there, it's just stabilizing, keeping it stable.
Yes. Yes. Yeah. Yeah. Yes.
Is anyone looking at stage 4 cancers?
Yes.
On targeted therapy,
Mm-hmm.
where you lose all evidence of active disease in the periphery, doing anything in the primary at some point in time?
So that's a good question. So the question was if you have a cancer where you treat with a medical therapy, so there's evidence of stage 4 disease, and you treat with a medical therapy, and the evidence for distant metastatic disease goes away. So let's say you had a tumor in the lung and there was some little liver metastasis. And you do treatment for a while and then there's no evidence of liver metastasis. But then there's a residual significant sized lung tumor mass. So I do think that in various settings we're moving toward consolidated radiation. Okay? So in certain settings where we reduce the cancer to oligometastatic disease, sometimes we do local treatment for that, which could include radiation, depending on the tumor, it could be radiosurgery. Sometimes if somebody starts off with really bulky cancer in the middle of the chest, they'll do involved field like thoracic consolidative radiation of the chest, but that's kind of on a case-by-case basis.
It's like fine weather. For example, I'm an example of that, where
Yes.
there's a heart failure event,
Yeah. Yes. Mhm. Yeah, so there's another scenario where you treat the cancer and then one site progresses. Okay, oligoprogression. There's good data that radiating that one site of progression is beneficial. So, yes.
Just one more thing that's running through my mind
Yes.
about this. If you have evidence of sclerosis of tumor cells indicative of death, is what I've been told, is that just a theory of thought, or is it, are there truly cellular death? Is if you stop medicine, will they come back?
Are you talking about sclerosis in the bone?
Yeah, I'm talking about, yes. That
So-
one particularly.
So it's hard to know what sclerosis in the bone is. You can get sclerosis in the bone after the bone has been radiated, sort of as a scarring effect. You can get the cancer, if the cancer responds to the medical therapy and the cancer goes away, then the bone will kind of rebuild around that to kind of fill in the hole, as it were, and it can be termed sclerotic looking. We don't have any test at this time to know whether there are any viable tumor cells. We don't have any test that can say, is every last cancer cell gone? One of the areas of research that is interesting is looking for cancer cells in the blood. And if the cancer cells in the blood go away completely, that's a good sign. But how we implement that medically at this point is still an area for research. Okay. So, one of the more recent improvements in treatment is neoadjuvant therapy, so giving treatment before surgery. So often present with a stage 2 or stage 3 lung cancer, we will give chemotherapy before surgery to shrink the tumor down before it's taken out. And Checkmate 816 was a trial where people received standard chemotherapy before the surgery with or without the immune therapy Opdivo. Here, this shows that the pathologic complete response rate was 24% with the chemo immune therapy and 2% with the chemo alone. So this is complete loss of cancer cells, so a marked improvement in that. But more importantly, it improved the progression-free survival and appears to also be improving significantly overall survival. So this is a recently FDA-approved treatment where we give chemotherapy plus immune therapy before surgery. And at Duke, we are pretty much doing this for most of our stage 2 and stage 3A lung cancers, where we give preoperative chemotherapy plus immune therapy. So I think this is a big step forward. So molecular therapy has been tested in early stage lung cancer. So this is a trial called the Adora trial, where patients had surgery, they received chemotherapy, and then they were randomized to get the Tagrisso or placebo. It showed a dramatic improvement in progression-free survival. For molecular therapy, more than immune therapy or chemotherapy, it's not entirely clear if progression-free survival is going to translate into more cures. So I think that this is an FDA-approved treatment, and it's being offered to patients with different degrees of enthusiasm by medical oncologists. I would say older, more conservative, stodgy oncologists, like myself, are a little bit skeptical, and we want to see the overall survival data, whereas with others are just jumping in and saying the progression-free survival, what we call the hazard ratio, is so impressive. Oh, this is great, let's just go with it. So certainly a very important finding and a new treatment option. Okay. So conclusions in lung cancer. You know what, 20 years ago, like at the first LCI meeting or something, I could have covered lung cancer in like 30 or 45 minutes. And I apologize, I just can't do it justice right now, like in that amount of time, which is a great step forward. Okay. 20 years ago, good. Now I can't, not even close. And that is a measure of our progress. So, what's important? There's hope now for all lung cancer patients, whether they have early stage disease or late stage disease. Hope is really important. It's important to cure people, but it's important that we can give all people hope, and now we can give all people realistic hope. I didn't talk about screening. We have good data that screening for lung cancer in people who have a prior smoking history can identify more early lung cancer and save lives. That's really important, especially getting screening to underserved communities. Smoking prevention and cessation decreases lung cancer. We need to continue to focus on that, particularly on efforts to prevent young people from smoking. That's when people start, teenagers and early adults. So upping the taxes, if an 18-year-old who's making minimum wage has to choose between getting a new phone and smoking, they might just decide not to smoke. As I've told my medical students, nobody when they turn 40 says, you know what, I'm going to eat better, I'm going to exercise, and by God, I'm going to start smoking, I just owe it to myself. Right? It's all about getting to the teenagers. Biomarkers have been a huge step forward. It allows us to choose the right treatment for the right patient, get better outcomes, and less toxicity. Molecular therapy can effectively hit the target and give great benefit. Immune therapy can provide durable cancer control, and as someone asked, are we curing some people with advanced disease? I think we are. Every week, I see people coming in 3, 4, 5 years out doing really well. Molecular therapy and immune therapy in early stage disease is improving the cure rate. Huge step forward over the last few years. Research is leading to better therapy for all stages of lung cancer. We've made a lot of progress, but we can't stop, okay? There's hope, but until we're taking almost all lung cancer and curing people or turning it into a manageable chronic disease with good quality of life, we're not where we need to be. So we made tremendous progress, but we should use that tremendous progress to motivate ourselves to do even better. And like I said in the beginning, the amount of resources and attention that any given cancer type gets is largely related to the advocacy group that's pushing behind it. So what you all do, being here today, and what you all do at events and otherwise is of critical importance. And even talking to your friends and getting them involved or making them aware and getting rid of the stigma of lung cancer. Okay. So thank you very much for your attention. It's been an honor to talk. It's been an honor to be involved with lung cancer research over the last 20 years. So I'll be hanging around and be happy to ask questions, to answer questions. Thanks very much.